Welcome to Texas Heart Institute podcast series on the Living Legends and Luminaries in Endovascular Medicine. I'm Zvonimir Krajcer, an interventional cardiologist at Texas Heart Institute in Houston, Texas. Our special guest today is my dear friend and my idol, Dr. Frank J. Veith. Dr. Veith was born in August of 1931 in New York City. As Frank mentioned in his memoirs, The Medical Jungle, he was shy and an average student throughout his primary and high school education. In spite of being an average student up to this point, Frank found a way to be accepted to study medicine at Cornell College in Ithaca, New York. He graduated from medical school in 1955 and ranked first in his class. Next, he decided to pursue a surgical internship at Columbia Presbyterian Medical Center in New York. Upon completing 1 year at Columbia, he obtained surgical residency position at Brigham in Boston, working under future Nobel laureate Dr. Joseph Murray and also Dr. Frank Moore in the field of human organ transplantation. This followed by ROTC obligation to serve as a chief of surgery at a large Army hospital in Fort Carson near Colorado Springs. As stated in his autobiography, the Army experience was a game changer for Frank. This was where he performed an abundant number of operations that allowed him to develop necessary surgical expertise and also confidence, which he was lacking before. At the end of a 2-year stint in the Army, he returned to Brigham as a chief resident, again under Dr. Moore. Due to a rigid hierarchy at Brigham, and without seeing any future there, he accepted a position in Cornell affiliate Bellevue Hospital in New York City. There, Frank's interest in innovation and research began by applying and receiving NIH grant on artificial oxygenation by venous bypass, which was the precursor of today's ECMO. Due to limited opportunities at Bellevue, he accepted an academic position as an associate professor of general and also vascular surgery at Montefiore Medical Center in 1967 in Bronx. There he initiated clinical kidney transplant service as well as early research in lung transplantation. For his program in this area, he received an NIH grant of over $1 million per year, which he continued to receive for the following 14 years. In 1971, he became chief of vascular surgery division at Montefiore. There he performed the first successful single lung transplant in 1972 that was later published in 1973. Parallel to organ transplant, Frank's other area of interest in the early 70s was limb salvage. He developed an innovative technique of popliteal to tibial artery bypass with the use of veins and or ePTFE ePTFE grafts. Early on, he realized that good quality angiographic imaging was essential to clearly define arterial anatomy. By using his innovative technique, his limb salvage rates for critical limb ischemia at that time was 90 to 95%, which was unparalleled in the early 70s. He pursued and adopted innovative endovascular techniques and technologies as soon as they appeared on the horizon. Frank's belief in endovascular procedure was very enthusiastic. However, he was not well received among his surgical colleagues. In the late 70s, he was one of the earliest vascular surgeons to adopt Charlie Dodder's technique of so-called doddering of peripheral angioplasty. This followed by another daredevil procedure, endovascular abdominal aortic aneurysm repair, which was performed with the assistance of Dr. Juan Parodi and Claudio Schoenholz from Argentina, and the procedure was performed in 1992 at Montefiore Hospital in New York. This procedure was the first of a kind performed in North America. His team soon modified the Parodi stent graft procedure to be used for other applications such as iliac artery, occlusive disease, and also a little bit later for ruptured aortic aneurysms. In 1996, at his SVS keynote address, Dr. Frank Veith predicted that within 10 years, 40 to 70% of open operations would be replaced by endovascular procedures. Nowadays, this has become a reality. For decades, he pursued a valiant crusade for vascular surgery to become an independent surgical specialty, which due to the turf battles within the surgical community did not become a reality. As a matter of fact, he was punished for his pursuit of this endeavor by being fired in 2005 from Montefiore Hospital. Fortunately, he was promptly offered a far better position at New York University and also at Cleveland Clinic, where he is much better appreciated. At Cleveland Clinic and at NYU, a Frank J. Veith Chair of Vascular and Endovascular Surgery was created. One of the most important achievements in Frank's professional career has been leading the Veith Symposium, an international multidisciplinary medical conference with the participation of many medical device and pharmaceutical companies. Now, in its 52nd year, the CME Symposium is considered the largest vascular meeting in the world, featuring over 700 speakers and up to 5,000 attendees. Dr. Veith, thank you for the opportunity to participate at Texas Heart Institute podcast on the Living Legends and Luminaries in Endovascular Medicine. You're a dear friend of mine and one of my idols in professional life. Now, in your autobiography book, The Medical Jungle, you write about 6 primary areas in your medical career that you are proud of. Can you briefly list them for us?
I guess the two most important, I also did some work in lung transplantation, which was transformative, but the two areas clinically that I'm most proud of is really, I was the originator of limb salvage surgery for ischemic gangrene and other ischemic lesions in the lower extremity. And I spent probably 30 years trying to popularize the fact that gangrene shouldn't always be treated by an amputation, a major amputation. So over the years, that became the standard of care. And of course, when I first presented it at various meetings, I was ridiculed, et cetera. But as I say, it became standard of care around the world. And most recently, we were also one of the innovators for endovascular techniques for limb salvage and popularized them when other vascular surgeons thought they were crazy. And now I think the endovascular treatment of lower extremity occlusive lesions endovascularly is one of the hottest areas in vascular treatment. So that's a big deal. My second area that I'm rather pleased with, also one that was originally for which I was treated very badly when I first presented it, was the use of endovascular grafts to transform the treatment of vascular lesions. And specifically, we were the first group, together with Juan Parodi, who did EVAR in the United States, really in North America. And I was fortuitous to be president both of a regional vascular society and the Society for Vascular Surgery as we were developing our endovascular graft program. And I made those grafts, that is endografts, for the treatment of aneurysmal, occlusive, and traumatic lesions. I made that the topic of my 2 presidential addresses with the proviso of advising all vascular surgeons to become endocompetent, lest they become obsolete and extinct. And for those two presidential addresses, I was also, I would say, poorly treated. Those addresses were poorly received by some of the then leaders, many of the then leaders in vascular surgery. But it turned out over the subsequent decade or 15 years that much of what I advised in that, particularly the presidential address to the SBS, much of what I advised came true. And at that time, I predicted that 40 to 70% of vascular lesions would be treated endovascularly in the future. And for that, I was ridiculed. How could that be? I would be spoiling all sorts of good open operations. It turned out I was wrong with that prediction, but wrong on the low side, because today we know that probably between 80 and 90, maybe 95% of vascular lesions requiring treatment can be treated either wholly or partly by endovascular techniques that we advocated now 20 years ago, more than 20 years ago, 30 years ago. So I'm pretty proud of that. And of course, throughout my limb salvage innovations and advice to other vascular therapists, and my endovascular advice to the same group of people, the interesting thing was we were treated very harshly by many of the others who practiced those arts. Now, I think both initiatives and concepts, that is the endovascular treatment of most vascular lesions, I think that's generally accepted around the world. And it will be accepted more and more as time goes on.
Thank you very much for this information. I wanted to go a little bit more into detail, because a lot of people don't realize and don't know that you were one of their earliest individuals that contributed in organ transplantation. How did this happen? Where did this begin? And tell us briefly about your research in this area.
That's also, I'm sort of proud of that too. I trained with Joe Murray at the Brigham, Joe Murray being one of the original kidney transplanters for which he got the Nobel Prize. And so I was pretty competent in transplantation when I finished my training and went to Cornell as a young surgeon. And I figured that the problems were pretty well solved with kidney and liver transplantation, but they were really totally unsolved with lung transplantation. So I originally started my research in lung transplantation. And at that time, the transplantation of a single lung in patients with pulmonary hypertension was deemed impossible because single lung transplants or a single denervated lung would have a high vascular resistance. And so we started our work in animals with single lung transplantation, ligating the opposite pulmonary artery to force all the blood flow through the transplant, which had never been done successfully before. And during some of those experiments, we observed that the pulmonary artery dilated as the entire cardiac output was forced through that pulmonary artery to the left lung. And we observed that as the artery dilated, an anastomosis of the pulmonary artery became a significant stenosis. And we then did pressure measurements and showed that the pressure across that stenotic pulmonary artery was what contributed the bulk of the vascular resistance to a transplanted lung. And when we made the anastomosis distensible so it could dilate with the rest of the artery, the vascular resistance of the transplanted lung went away or stayed normal, and the single lung transplant could sustain the entire cardiac output and the entire animal and patient. And we then proved that in patients, which led to successful clinical lung single transplantation. And of course, we were doubted when we presented that work too. It was published in Science and SGNO, and we think that it was a major contribution to single lung transplantation. We also developed methods to prevent anastomotic failure at the bronchial anastomosis using a telescopic anastomosis. That was the second big problem with single lung transplantation, obtaining a success. And the third problem was eliminating rejection. And with the advent of cyclosporin, we again showed that in both animals and man, that single lung allografts could work and could sustain the entire cardiac output of a patient or an animal. And it led to some early clinical successes on our part and others, which really facilitated what is now rather commonplace. That is the treatment of various pulmonary diseases with a single lung transplant.
Thank you very much for this information. Let's move to another area where you are a great contributor, and this is limb salvage. And please tell us a little bit about your early experience, and maybe you can mention the story of Carol Ligotino, a young tennis player that you treated in these early stages of limb salvage treatment.
Okay, Zvonko, that's a great question. When I went from Cornell Bellevue to Montefiore as a young vascular surgeon, I guess the late 60s, I wanted to do clinical work, and I was very interested in vascular surgery. And I wanted to do aneurysm and carotid surgery, which were the hot items of the day. But I didn't have many patients that fell into that category, but we had an abundance of patients with gangrene, a non-healing ulcer, ischemic limbs. And the treatment at that time, this was in the late 60s, early 70s, the treatment around the world for those problems, which had been tried with vascular surgery, attempted, didn't work very well. And the advised or the current thinking of the day was that those patients should be treated with a below-knee amputation and, quote, rapid rehabilitation. Well, that never happened to these old sick patients. So we cautiously started to challenge the thinking of the day that these patients should all have amputation. And we started to do various bypasses in the lower extremity. And much to our surprise and delight, they worked, both when the bypass went to a target artery at the popliteal level, and really our work showed that with good arteriography, you could visualize patent target arteries in the lower leg and foot. And we did bypasses both with vein and prosthetics to these arteries, and much to our delight and surprise, they often worked and enabled us to save these gangrenous limbs. And we presented that work at many of the prominent vascular and general surgery meetings of the day, including the American Surgical. And we were treated with, I don't say hostility, but with disdain and skepticism. We were the crazy guys in the Bronx. And we kept doing these procedures, and they worked. And over the years, other vascular surgeons realized that these procedures, as well as redo procedures when the first procedure failed, as it often did many months or years after the original procedure, that these procedures and redo procedures, often supplemented by transluminal angioplasty, which again we adopted early and were doubted about, that really probably somewhere between 85 and 95% of ischemic limbs that were headed for amputation could be salvaged. And we must have published many, many papers on various derivatives of this aggressive limb salvage approach. Again, the interesting thing was that we were doubted from the beginning by all our friends and many of the senior leaders in vascular surgery. But these procedures, when they're done carefully, can work. And that, of course, has been confirmed. And now limb salvage, both with open and endo procedures, are the standard of care around the world, and they're a very hot item because of the commonplace nature of ischemic lesions in the lower extremity leading to a threat to the limb.
Yeah, it's important to mention, and correct me if I'm wrong, but I believe you were one of the first ones that performed femoral popliteal and femoral tibial bypasses with veins or artificial conduits. Is that correct?
Yeah, absolutely. And we're still talking about that. We have a series of patients that got infrapopliteal bypasses with a remarkably good limb salvage. These are all patients that were headed for amputation with intractable gangrene, really severe true rest pain, or non-healing ischemic ulcers. And we, over the years, probably the last 30 years, we've evolved with some other groups, a series of patients that, because they didn't have a suitable vein for a distal bypass, either because of a previous unsuccessful procedure or just bad anatomy, we were able to use PTFE bypasses, sometimes from the common iliac artery, sometimes the external iliac artery, most often from the common femoral or superficial femoral artery, to an artery in the leg or even the foot. And some of those bypasses, not all, but some of them worked. And many of them saved the limb for up to 13 years when the patient survived that long. Of course, these patients that require these procedures have a very high mortality from their intercurrent comorbidities, mostly heart disease. But when they do survive, they have a very respectable patency rate if the bypass is constructed with great care, particularly at the distal anastomosis. It has to be technically perfect. And again, we're still having trouble getting some of these articles accepted for publication because people don't believe us. And it's interesting, when I interview candidates for a vascular fellowship or residency, I ask them, what do you think about PTFE tibial bypass? And they all say, that's a ridiculous procedure. It should never be done. Well, that obviously is incorrect. And we're going to get the paper describing this experience with some very long survivors, that is over 4 years up to 13 years, with patent tibial bypasses and a successful limb salvage. It's going to be presented next month or in the next couple of months at the Society for Clinical Vascular Surgery.
Well, thank you very much. I wish we would have more time to talk a little bit more in detail about it, because you have perfected this technique and also extended the longevity of those bypasses below the knee with the creation of the arteriovenous fistula to increase the blood flow. But there is another area of great contribution that you have achieved, and this is in endovascular repair of abdominal aortic aneurysm. When you performed in 1992 this procedure, first in North America, with assistance of Juan Parodi and Claudio Schoenholz. Now, I'm familiar with obstacle.
Michael Marin, by the way.
Right, and Michael Marin, I'm sorry. I was particularly interested in difficulties and troubles that you had actually in getting this procedure approved at Montefiore, and also making sure that the industry provide you and allow you to do the stent that was already approved for clinical use.
Yeah, I mean, we did write a book. It's one of the chapters. It was amazing. In the beginning, J&J had the Palma stent, and the Palma stent was part of a large Palma stent was part of the surgeon-made endograft that we, with Parodi and Marin and Schoenholz, used to do our first case. And the irony was, we had great difficulty within our own institution, but forget that for the moment. We had trouble with J&J Interventional, which didn't want to let us use the Palma stent because it might interfere with their approval of that, FDA approval of that stent for use in the coronary arteries. And so we had, Mike Marin and I had a dinner meeting with the president and other leaders of J&J International. We had it at the Newark Marriott Airport, and we kept telling these guys, we got to do this patient. He's dying, and he's got a very symptomatic aneurysm, and Juan wants to come up with Claudio and help us do this first case. And you've got to let us use the large Palmes stent, which they were making in Argentina. And they kept saying, no, no, no. And we were sitting in a corner of the dining room at this Newark Marriott restaurant. And the two guys from J&J couldn't get out of their chairs because Mike and I were sitting, they were in the corner, and we were sitting where they could get out, and we wouldn't get up from the table. And the waiters were cleaning the chairs and floor in the restaurant. Everybody had left. And finally, the president of J&J Interventional said, look, I'm getting exhausted. I got to get out of here. You guys do whatever you want. And that led to the ability to use a Palmes stent analog. And then we had great difficulty getting Juan Parodi up to the United States to help us with this first case. And then we had great difficulty in our own OR because we had really pedestrian digital fluoroscopy in our OR using an old fluoroscope that the research cardiologists had thrown out. Marin and I rescued it from the garbage bin, and we put it in our OR and were able to use it. And when Juan Parodi and Schoenholz came to our OR, they expected, we were in a great white academic center in the Bronx. And when they saw what we had, the primitive nature of our equipment, our OR, X-ray techs that never worked, so forth and so forth, they didn't want to do the case. And so we kept after them, begging them. And finally, we got the case done. And with great good fortune, because it was a tough case, it worked. And the aneurysm was excluded. The guy's pain was relieved. It was a remarkably successful first endovascular repair. Now, with all the improvements in EVAR endografts from industry, et cetera, EVAR has become the standard of care. And we did a couple other cases with Juan Parodi that did pretty well. One did not. But Marin and I launched this endovascular graft program for other lesions that didn't require the large Palmes stent, but could be used with the regular FDA-approved clinical stents. And we were able to accumulate, several hundred patients that were otherwise untreatable by open surgery for various reasons. And these procedures unbelievably worked. And when we presented them to our colleagues, my good friends, young Turk vascular surgeons, they didn't believe us. They thought we were lying. And Marin and Parodi and I came to this vascular surgery biology club where all my middle range vascular surgery leaders were participants. And we presented this stuff, and we were, to a man, nobody else in the room believed us. They thought we were lying. And so Parodi and Marin and I went out for a beer after it, and we were very depressed because here we thought we were telling these guys about the future and what they should do and giving them a heads up, and all they did was disbelieve us. So instead of being, leaders and messiahs, we were pariahs, and it was very depressing. But gradually, over the intervening 5 to 10 years, enough people started to do these procedures, and they worked. And now, of course, instead of having to make the grafts ourselves, the primitive grafts, just sewing a Palmes stent to a vascular graft, putting it in a sheath, putting it on a balloon, and deploying it over a wire. Now we have industry making these grafts, and they're everywhere. They're in the coronaries, they're in the renals, and they're in the lower extremities, and they work. Now, that led to ultimately to vascular surgeons realizing that they had to become endocompetent or they weren't going to survive. And they have. And together with interventional cardiologists, interventional radiologists, vascular treatment around the world has been transformed by both Peroty's and our innovations and very early primitive work, which unbelievably worked.
Well, thank you very much for this detailed information. I would like also to ask you, and you write in your autobiography, The Medical Jungle, and you gave a phrase there that you were treated as a person going against the grain, and also you could say rebel without a cause. And this was particularly true as far as the Surgical Society is concerned, and also at Montefiore. So I personally think that you were a rebel with a very good and justifiable cause, because you were fighting for future of endovascular medicine that a lot of your colleagues didn't understand that was coming, and that this was truly the future. So I have to salute you for that fortitude, determination, and hard work, because like you mentioned at the beginning, it has become a reality, and you embraced all the specialties involved in endovascular care: radiologist, cardiologist, neurointerventional radiologist, and neurosurgeons as well. So you are unique in that way, because you saw the future of endovascular medicine. But maybe you can mention a little bit difficulties that you had, including what happened at Montefiore when you pursued that goal.
Well, that again is a great question, Vanko. The book is not an autobiography. It's really a book that uses my experience to reveal the malign nature of man. Man, it's still, you see it today everywhere, motivated by a lust for power, self-interest, jealousy, and greed, and resistance to change. Those 5 things. And that's what the book is about, because that's what we faced during most of the phases of our work. And it's going on today. It occurs throughout human experience. It occurs with lawyers, with business people, certainly with politics. There's a lot of bad traits that man in general possesses, and those have to be overcome, both with good fortune, which I really had. I didn't expect success. I was very lucky. Not great insight or vision. A lot of it was luck and persistence. And that's what the book is about, The Medical Jungle. But you see it today everywhere. You see it in our politics, in our diplomacy, certainly in business, and surprisingly in medical administration. You'd think in medicine those malign characteristics wouldn't occur, but they do, to a flaw. And we were hampered by our hospital president, Montefiore, who was both resistant, jealous. He wanted us to be cardiac surgery center in New York City, where we had Cornell, Columbia, NYU, Mount Sinai, really great cardiac surgery institutions. Montefiore could never achieve that. And he didn't realize he had a golden goose with his vascular surgery group, because we were doing all these new things. And so we had a lot of resistance within our institution, and actually jealousy. When we did the first case with Juan Peroty, Mike and Claudio, we wanted to get some public exposure because we thought it was going to change the world. And our president wouldn't let us do that. Even when I said to him, you can be the pitch man, you can go on television, talk about this, he didn't do it. He wanted us to be a cardiac surgery center, and he was not the most ethical guy. He had a lot of political connections, et cetera, et cetera. He's now passed away, so I can talk about it, I suppose. But the fact was we had resistance on all fronts. motivated by these malign human characteristics of he wanted to rule the world. And he did. He was the master of hospital care in the Bronx, and he got away with it. And parts of the hospital are named for him, et cetera, et cetera. So young people in any field have to realize that's what the book is about, that these malign characteristics of people, other people will stand in your way, but with luck and persistence, maybe changing jobs, et cetera, sometimes you can overcome these things and achieve success that benefits society, patients, and really the world.
So, Frank, thank you for this detailed information. Now, I have one more question to ask you, and this is related to Veith Symposium. You are now in a 52nd year of this symposium, which is totally unheard of in any kind of meetings worldwide. And I have to congratulate you for your perseverance, your determination to pursue that goal with education, and encourage your colleagues to present the latest information on endovascular and vascular medicine. Can you tell us a little bit about the beginning and what is happening at the present time with the Veith Symposium, and what is the future of it?
Well, we hope it goes on long after me, and we're trying to develop a succession plan and so forth. But it started as a tiny meeting. It was started by Henry Hamavici, an old-time vascular surgeon who ran it for a couple of years. We had maybe 50 attendees and maybe 9 or 10 speakers from expert speakers. And it was in one of the Hotel Roosevelt, the Fleabag Hotel in Manhattan. And I took it over when Henry retired. And we were very lucky. And we did a couple of things that turned out, again, fortuitously to be right. The most important one was embracing industry, because industry, both in our societies, our vascular societies and elsewhere, had always been thought of as the poor sister who could give us some money and help out meetings that way. And we originally embraced industry as equal partners, because without them, we couldn't have the tools, particularly specifically the endografts and other endovascular equipment, to do the new things that we were doing. And so we featured industry very prominently. And of course, they liked that and they supported us. And our other good luck were two things. One is we were in New York, which is an easy city to get to. It's sort of like Houston, from all over the world. And we originally tried to get leaders in vascular surgery who were doing innovative things from all over the world: Thailand, Japan, Australia, Europe, et cetera, South Africa. And we, with the help of industry, could bring them to New York, where they told us about things that we in American vascular disease treatment didn't know about. And so that led to growth of the meeting and success. And the other very fortuitous thing that we stumbled on was, because we wanted to get lots of these good speakers from around the world on the program, we didn't have enough time. So we evolved the short talk, a 5 to 6 minute talk, which nobody else was doing at the beginning. Now everybody's copying it naturally. But we evolved that short talk format, and that led us to the ability to have lots of people presenting interesting things rather than just a few. And that contributed to the success of the meeting. And of course, all those things we're trying to promote and continue, as well as introducing new things like associate faculty programs for young surgeons and cardiologists and radiologists to present exciting new stuff. So the meeting has become really a virtual textbook of what's going on that's new and exciting. And it's far more up to date and unbiased and clear than textbooks or other perhaps more biased means for obtaining surgical education. And lots of young people get their start in the vascular world academically by presenting at our meeting and having lots of people hear it or see it, or see it on our library and stuff like that. So we hope the meeting continues. We know that everything in life doesn't continue necessarily, and one needs to be lucky and somewhat innovative. And hopefully the meeting will go on under the leadership of some of my colleagues, Enrico Asher being the most prominent one, even if I'm not around to do it. And making the program is a hard task, but I think it pays off with meetings that are well received and good, and hopefully will continue to be successful in a very difficult world. Travel is hard. Inflation is a problem. We're very involved and subject to the whims of political actions and so forth. And we would like the United States to stay successful, but we need input in vascular treatment from all over the world, because unlike some of the thinking in the United States that we're the center of all progress, we're not. Juan Parodi did his work in Argentina. Volodos did his work in the Ukraine, in Russia. The United States is just one of many places where progress can occur. And our job, unlike some of our societies, is to feature the work from all over the world.
Well, Frank, thank you also for the opportunity for me to participate at Veith for the last 3 decades. I have learned a lot, and this is for me one of the best meetings anywhere.
Well, you contribute a lot, Zvonko. You know, you do some things that other people don't believe, which turn out to be right. And you can't win every time, but you can win lots of times.
Both of us are rebels with a cause, right?
Yeah.
Definitely. Well, Frank, thank you very much for the opportunity for you to participate at the podcast, Living Legends and Luminaries in Cardiovascular Medicine. Thank you once again.
It's my pleasure, Zvonko. Lots of luck and stay well.
Thank you. Bye.
Bye.